of Promoting Vaginal Birth Initiative. What you can go ahead and do is you can put your name into the chat box and your hospital, so your name and what hospital you're from, and Ellie will take a nice attendance. But we'll go ahead and get started here. So the overview for our call today is we're really going to give you all an introduction to ILPQC. What is the structure of ILPQC? What supports do we offer? We're going to go into a very brief, like QI 0.1, not even 101, of what is quality improvement. We'll go over what the framework we use at ILPQC for quality improvement. And then we'll discuss what is your role as a QI team lead, or maybe a provider champion or nurse champion. What does that really look like in an ILPQC initiative? We'll then talk about how to be a successful QI team lead. What are some of those key elements and strategies that we encourage for every team lead to do? We're going to talk a little bit about creating buy-in and engagement, and then we'll begin where to start. And if we have time, we might be able to do some prioritization matrix. This is the ILPQC team. I like to show this slide because many of you might be new to ILPQC, and this might be your first initiative to us. Our executive director and also OB lead is Dr. Ann Borders. And then we have Dr. Leslie Caldarelli and Dr. Justin Josephson, 2 J's there, who are our neonatal co-leads. Patty Lee King is our state project director and our quality lead. And then you have Dan Weiss, many of you know him, and myself. Dan is a project manager and I'm the nurse quality manager. We also have Kellyanne, who's our data system developer, which I'll go into a little bit more about our really awesome ILPQC data system. And then we have Aisha Johnson and Ellie Seuss, who are our project coordinators and really your go-to point people for many things. So this is the ILPQC initiative timeline. Our inception occurred in 2014. And as you look at the different blue and orange boxes, hopefully you might be able to identify something that you've participated in. You might look and be like, oh, I remember for the neonatal teams when we did do golden hour, that rings a bell, that makes sense. That was ILPQC. Or some of you may be like, oh yes, we did do, a hypertension initiative with ILPQC back in 2016 to 2018. Currently, our new 2021 initiatives are our Promoting Vaginal Birth, that's our obstetric initiative. Our neonatal initiative includes our antibiotic stewardship, which is basic. It's Babies Antibiotic Stewardship Improvement Collaborative. And then we also have one for our OB that's going to launch in May, statewide, May 2021, which is our Birth Equity Initiative. We have 3 pillars that really support ILPQC's quality improvement success. So what you'll see with these 3 pillars first is that creating a foundation, which includes our support and collaboration across our key stakeholders. And then we create opportunities for quality improvement. We have a rapid response data system that reports back to teams and drives change. And then last but not least, our 3rd pillar is our quality improvement support, where our goal is to leave no hospital behind. We provide lots of different quality improvement support services to hospitals and opportunities to connect. We do have our monthly webinars and calls. We also provide what we call, virtual to virtual face-to-face meetings. This includes our face-to-face meeting that will be held virtually this year on May. And Ellie, if you can put the date in the chat box so people might have it, that would be great. So save that date on your calendars. And then we also have our annual conference breakout sessions. We have key player site visits. We do this virtually now in the time of COVID, where ILPQC can go in, and what we call key players. It's individuals who are part of the QI team, and maybe it might be some administrative people that aren't part of the monthly team who need to come together and really workshop a few things, and ILPQC provides support that way. We also have grand round presentations that are for all of our initiatives. And also we call them provider meetings. Sometimes it's OB provider meetings, which is really short, or pediatric team meetings if you're a neonatal team who's on here. We have lots of different resources that we provide to you as our team leads. And your general QI team. We have paper and online QI toolkits. PVB, if you're here for PVB, your team was sent a paper binder of a toolkit, and it is also online. And then the neonatal teams for basic, you have an online toolkit. I do want to make sure everyone hears me loud and clear when I say our toolkits are living documents. They are often edited and changed based on your response and what you guys share with us of what your needs may be. So always go back and check the online resources first as we update things, as we learn things, because we're always doing our own small PDSA, personal or small tests of change at ILPQC. We also provide lots of education materials. We have some really exciting things coming for both basic and for PVB. We have our monthly newsletters and then also these recordings. And then last but not least is our ILPQC rapid response data system and our real-time reports. Our rapid response data system is something we are extremely proud of at ILPQC, and that is very sought after and discussed by other PQCs across the nation. How it works for you, and I'm not assuming everyone's been involved in an ILPQC initiative or been on a team before, so I'm going to go through how this works with our rapid response data system, is we really do some time where we collect data. So you collect data on what's called structure, process, and outcome measures. And when we're launching next month for basic and PVB, you will notice in your slides next month, you'll have your different structure, process, and outcome measures, and actually even balancing measures stated. So look for those more specific. Today's a general call, but specific to your initiative, you'll look for those next month when they share them. So you'll collect your data, and then you're going to input the data into your ILPQC data system. We're working really hard right now to upload everyone who needs access into the REDCap data system. You should begin to get access early next month. And this is for you to be able to do your baseline data collection. After you are able to put in your data, you want to do a review of your reports during your QI team monthly meetings. These reports are super useful for you. We're developing some really unique and really exciting dashboards based on your feedback. And if anyone attended our PVB data call, you may have you may remember me informing you that we have a new platform we're going to be using, and that was just direct feedback from you guys. So there's going to be some exciting new ways and features to our data system. What's really cool and unique about ILPQC's rapid response data system is once you enter your data, you can hit click and it will automatically show you graphs of where your team is at, how you guys are doing, and you compare it across the cumulative data from the collaborative, so all across the state of Illinois and into the lower St. Louis, Missouri area. And then also just a little plug that we really encourage you guys to use your data to drive your quality improvement change. Here you can see I'm going back to the ILPQC's 3 pillars, and I want to elaborate slightly more on this QI support. And this is going to be important when we talk a little bit about your role as team leads. So ILPQC really has the goal of leaving no hospital behind. We are a free service to you where we can provide support on many different levels. Each hospital team is working to implement the evidence-based care guidelines for each initiative, whether that's basic and PVB. And so we ask you to basically monitor your monthly data, and we will ask you to connect with us for QI coaching calls if we notice teams aren't reaching goals. We also offer for teams who may not have other resources that we can come in and provide virtual grand rounds. We do focus QI topic calls based on these coaching calls that we do. Often a lot of teams will share with us, hey, Autumn or Ellie, we're noticing this, and this is a really big barrier. And so we need to figure out some strategies. Then what we'll do is we'll go back to ILPQC Central, we'll talk, and we'll say, hey, you know what? We actually have a few hospital teams that have been successful in this area. This is why your data entry is really important. We'll reach out to those successful hospitals, and that's part of our collaborative learning where everyone comes together for a topic call. We call it like our candlelit dinner call, where people can really intimately, these calls are usually around 10 to 20 people who can workshop and really dig deep and ask some questions to a hospital who's been successful with a strategy. I already mentioned that we have key players meeting, and then last but not least, we have something called a regional strategies meeting. This is reflected in our partnership with your perinatal network administrators, and we come into these meetings and we help relay the information and provide status of what that whole network is doing. What is QI? So, what is quality improvement? Simply put, quality improvement is a systematic way of making things better. It has 3 key ingredients, which include will, ideas, and execution. Will is really the motivation and drive to do what it takes to create change. That's the simple definition of will, and that's your first ingredient. Your second ingredient in a successful quality improvement is really ideas where you come together, workshop, and come up with ideas of the base design of your new system or new way of doing things. And last but not least, but a very important one, is really putting these ideas into motion using a rigorous system. And again, I'm going to go back to this systems changes. Now, ILPQC, we use a framework, which is from IHI, and it is a framework for developing, testing, and implementing changes for improvement, and it's called the Model for Improvement. It really is made up of two parts. The first part you can see is this box. I don't know if you can see you can nod. Do you see my cursor moving? Perfect. So this first box, the aim, measures, and changes, it's really addressing three fundamental questions. And then the second portion that this consists of in this model and this framework is engaging and learning from what we call small tests of change, or PDSA cycles, plan, do, study, acts. PDSA cycles are really honestly crucial to the successful implementation of your work. They help you test ideas in a rapid way, in a small scale. It helps your team identify your idea for your improvement and plan the change, which is part of your P. Then you want to try your change on a small scale, observe your results, which is your study, and then ask them what was learned. Was this good? Was this bad? Do we need to tweak it? So in general, your hospital's QI work is thinking about what changes can you make through your process system or systems, process flows, your systems that you already have, and then test them with these PDSA cycles to reach the initiative goals. I want to be clear on what quality improvement is not. Quality improvement is not just a simple mass education. Okay, everybody, here's what we're doing, learn about this, and we're good to go. It is an ingredient to quality improvement, absolutely, and a very important part of it, but it is not just simply that. It also is not just a large rollout of like, okay, we come up with this idea and we're just going to roll it out. We're going to have a checklist, and here's the checklist, everyone, let us know what you think. There's several reasons we encourage those PDSA, those small tests of change. The reason is it includes maybe you might learn something and maybe you need to adapt something, or maybe you just need to abandon it altogether, like, oh, that didn't work, or maybe you will adopt it after just a small tests of change. But let's go in a little bit deeper of what that would look like if you did do these cycles, these small tests of change, and you're implementing a checklist. So here, this comes from the improvement guide, the IHI framework, the model for improvement. It begins with really your hunches, your theories, your idea. Remember, that's like part of your ingredients for quality improvement. And you'll do your first PDSA cycle, which maybe that's just trying your checklist. Like, let's say you have a checklist for basic that we've kind of said, hey, here's some example checklists, try it out. Maybe it's a checklist for if a patient is meeting ACOG MSFM criteria, and it's a decision huddle checklist or something along those lines. So imagine you're implementing this checklist. What we would encourage you first to do is try it out with one nurse, one patient, one provider on one shift. So maybe you try it out with a day shift nurse and you say, okay, let's see how this works. You plan for it and you recruit your people. Often it's those who are involved in your QI team. And then you do it. You all come back together, gather feedback and say, how did that work? What did we like? What didn't we like? That's your study. And then you move into your act. All right, are we going to keep this checklist because it went really, really well? Do we need to edit any checklist? And then you're going to do another PDSA. So maybe this is doing the same thing. So you tweak the checklist a little bit. You did it with one nurse, one patient, one provider, but you did it on a different shift to see, hey, that worked really, really well. We made the small tweak. Let's make sure that actually works well on night shift. So night shift, they try it out. They really like it. They're like, this actually worked out pretty good. Now you say, okay, let's do it on a little bit of a bigger scale. Let's do it for one entire shift. So that one nurse and that one provider do it together with various patients for that one shift, and then so on and so forth. What I really want to encourage everyone to do as QI leads or team leads in these upcoming ILPQC initiatives is remember not to overthink it. Start small. I often, in my quality improvement work and one-on-one support to teams, realize that, hey, teams are doing a lot of quality improvement work. Sometimes they just need to take the step back and actually implement that. So Remember, don't overthink it. It's really small, really easy implementations before you go big, because quality improvement is not one big massive rollout. It's doing small tweaks, making sure it's really, really great, and then doing your rollout. Ellie, I'm seeing the check or the chat box pop up. If any questions come up, will you just let me know? And I'm happy to answer any questions as they come in. So what does it mean to be a QI team lead? Let's see, is it gonna switch for me? Perfect. So there's several different things that the QI team lead is responsible for. Now this might be the RN champion or the provider champion, but we are asking you to involve those who are working directly with the process and the care for patients. So as the team lead, we want you to look at unit leaders, unit educators, multidisciplinary direct care members. So maybe for the NEO team and you're thinking about your basic and antibiotic stewardship, maybe you invite someone to your team who's an obstetrician who is maybe involved in the Promoting Vaginal Birth Initiative, or someone else who's interested in antibiotic stewardship to learn more about their process for the diagnostic criteria for choreo and communication tools. Maybe you invite even an L&D nurse to your basic antibiotic stewardship team to just help communicate and talk about those strategies. For PVB, maybe you're actually thinking, hey, this is really great opportunity for us to engage our patients. We know we're going to have to do some education. We know we're going to have to change a few things. So maybe we invite a patient to be on our team with us. So it's involving lots of people. The next thing that they're responsible for is either attending or having someone attend the ILPQC monthly team webinars. Our webinars are rich with so much information, so many tools. And also we have expert speakers coming in. We have team talks, we call them. Team talks are where we invite teams that we've noticed have been successful in areas. This is why your data entry is so important, because we really do look at it often at ILPQC. And so we invite them to come and provide a quick team talk. Hey, what are you working on? What have you found to be great? What successes have you had? What were some of your barriers and challenges? What strategies did you implement to overcome those barriers and challenges? So just encouraging everyone to make sure someone is representing your hospital team on those monthly team calls. The monthly team calls, so everyone will know, starting January 2021 for M&O, or not M&O, excuse me, for basic teams, they will be held on the third Monday of the month. So you can kind of just cue that up. And then for the PVB teams, they will be held on the fourth Monday of the month. If any of you have participated in the M&O initiative, you'll know that your M&O initiative, we had them on the third and the fourth Mondays of the month. So they've kind of just done that because we've moved the other M&O sustainability calls to a different section. Thirdly, is really supporting your team in timely submission of your monthly data and your quarterly QI reports. This is so important. I've said it for many, many times, but really using data to drive change is a key element in quality improvement. It really does show your team, hey, this is where we're at and this is where we're going. Are we heading in the direction we want to go in, or are we not heading in the direction we want to go in? Fourthly, we really would like you to please be mindful about receiving and reviewing the regular communications regarding your initiative. The reason this is really important is because ILPQC is often sending out items in those newsletters or in our communications that have been discussed on our previous calls. We also send out different links to webinars and other interesting things that you might be like to have. For example, if we're hearing about some CMQCC is holding an induction webinar about induction process flows with our partners over in Colorado, we would share that with you as just something you might be interested in attending, and you would get that via your newsletter. And then last but definitely not least is being able to facilitate progress towards your initiative goals. Another important part of being the team lead and your role as the team lead is really being responsible for, or not being responsible, who will lead your team in your systems changes as well as your clinical culture change. You know, we always say there's 3 ingredients to clinical culture change. The first ingredient is education. You need to make sure that people are aware and educated. The second thing is having data, looking at data. What is the data showing us? And then last but not least is some sort of feedback system, because if you've implemented a change and you're trying to change the culture, you need to be able to provide a feedback saying, hey, we did this really, really well, but next time we need to remember to do A or B, because we need to learn from our mistakes and learn from the things that maybe we might have accidentally missed or what it may have been an oversight. So that's a key element in the clinical culture change. The other thing that's really important for the role of the team lead is to serve as the point person for the ILPQC one-on-one QI support calls. So I pulled up the slide that I already shared with you that you can see here on the screen, because as the team lead, ILPQC will reach out to you and we'll say, hey, we need you to give a team talk because you guys have been successful. Or, hey, we noticed this is an area that maybe might need some help. What do you need? Help ILPQC know if we need to develop certain tools for you. And you, as the team lead, are responsible for responding directly to ILPQC email requests. I want to give you all a quick sneak peek of what our QI support cycle looks like and how it pertains to you. Each quarter, ILPQC provides a QI support cycle. So many of you have been involved in our ILPQC initiatives and may not have even realized that this is what's going on. What we do is ILPQC at each quarter and based on the different months has a system that's in place where we, like you, review data, look at what the data is telling us, to determine, okay, where can we offer help? What do teams need help with? Who can we reach out to determine what strategies are good and what strategies are bad, or what maybe we're lacking. And so we provide this quarterly review and quarterly QI supports to our hospital teams. So what you need to know is that the first month in each quarter is really when we're going to reach out to you. So if your team is someone who we'd like to share more strategies on, or if your team is someone that we want to make sure and just check in on, you'll get an email around the first week, the first month. So the quarters you can see here in the box in this corner right here. I've identified which of the 4 quarters we have. Our quarters start in January, and quarter 1 is January, February, March. And so you will not get emails starting in January because that's the start of our initiative. But our first round of QI support would probably begin in April, July, and August. So those are the times that ILPQC will be reaching out for hospitals to determine if they can give us a QI topic call, or if ILPQC needs to create different materials or offer different supports. Ellie, I'm seeing some stuff in the chat box. Is there anything that I need to respond to right now?
No, I've been able to answer all of them so far. I'll let you know though.
Lovely, perfect. And of course, you're welcome to come off mute, everyone, if you need anything. All right, so we've kind of walked you through a little bit about what is ILPQC, what is just a really basic understanding of quality improvement. Okay, so what is my responsibilities in this quality improvement project with ILPQC? And just to remind you, it's that keeping connected with ILPQC, which includes your webinars, the newsletters, the emails, all those other things, including your data. But what are really okay, Autumn, I get it. But what are some strategies? What can I do to be a successful QI team leader? Help me out here. I want to do a good job. Just give me an idea. Well, team leaders are really the point person, and it's simply put as being the planning and the executing of the ILPQC initiative. So the 2 phases, which includes a planning phase, and those are the interactions with ILPQC. So those are okay, so ILPQC covered this webinar. They've are really encouraging teams to start a labor culture survey, or maybe for basic, they're really encouraging teams to really start early with their EMR work because EMRs are really important for the antibiotic stewardship and putting systems in place. As we all know with EMR and EMR bills, those take a very long time. So we want to start early on those. So it's the interactions, attending those monthly team webinars and the calls to learn about what resources we have, what we're currently creating as action items for the team, and the collaborative. And also, like I mentioned, looking at newsletters because there might be important webinars that you might need to be aware of. ILPQC and previous initiatives have added trainings. And so we have different trainings that we offer for M&O. Many of you remember those trainings were for our OB providers. It was buprenorphine waiver trainings. It could also just be the interactions such as our key players meeting or hosting a grand rounds or learning about when our grand rounds come out for PVB. This could be a great example of learning, hey, they're developing labor management webinars and classes. So how to support that and strategies. So I need to make sure I'm aware of what's happening when that's going out and when our hospital team can request. And the second portion is the execution. And this is really where the team lead is the point person with the QI team at your hospital, really leading them and engaging them in conversations. It's ensuring that we actually document and create these PDSA cycles. It's establishing buy-in, which we will cover shortly here, right? And establishing buy-in is not just a top-down approach, it's also a bottom-up approach, right? So you can have, our administration, executive leadership that we can get buy-in from, but often with grassroots movement and when we can get people who are on the floor working in the trenches, we can get them excited and really energized about an initiative, we can see a lot of change happen as well. And then of course, it's reviewing and presenting data to your team and also to anyone else who might need it. For example, this could just be, maybe it's managers on the different floors. Maybe it's, a different administration. Maybe it's pharmacy, that you need to present some of the data. So seems very basic. When you look at this, you're like, okay, Autumn, this seems very basic. But after doing this for a little bit of time, sometimes we do think that these basic items, such as holding a monthly team webinar that's pre-scheduled, is like, oh yeah, I got that. But really going back to the basics is so important. Many teams that we've noticed who are falling behind really don't have these things in place. I want to make sure that we're really upfront, very clear of like, hey, what are really key strategies that will set your team up for success in any ILPQC initiative? First is really holding monthly team meetings that are pre-scheduled. Many things come up. People have lots of things. It's also important not to have a meeting just to have a meeting, but having them pre-scheduled, like determine as a team, how often do we need to meet? We encourage monthly team meetings. We have heard of some who say, hey, listen, this is really, a big struggle. We're going to do weekly. That's pretty rare. Some people do bi-monthly, but most people have their monthly team meetings that are pre-scheduled for them. It's also like what you heard me already say, it's the regular attendance on the ILPQC webinars and calls. And again, this does not necessarily mean you as the team lead have to be on those calls, but determining and saying and delegating down, hey, Ellie, would you please make sure that you are on this team call if that works for you? Or hey, maybe it's even at one of your team meetings doing a sign up, a monthly sign up with one person is on there and they take notes and they come back to your next team meeting, relaying the information and lessons learned from the webinar. Whatever it is, these ILPQC monthly webinars per initiative, so basic and PVB, are so important to the success and the work of what you guys are doing. Thirdly, it's very important to have agendas prepared for each of the meetings. This seems very, very silly, and you're like, okay, really? But no, when people have agendas and they know what's coming, it also can create a layer of accountability when you say, okay, here's the agenda. We need, Dan to have the data print, Dan to bring data and to share data insights, Autumn to bring, notes from the monthly webinar and lessons learned and possible tools for us. It really can help create that accountability and really set your team up for success. Fourthly, it's very important to have your data reviewed and to really review your data at each and every QI team meeting. Looking and saying, are we going in the direction we need to go in? How are we doing on each one of these elements? You heard me mention before that we're actually going to have some nice, really cool dashboards. This sneak peek for PVB, because this was just a meeting we had earlier this week. Our PVB dashboards are really going to be great. We're hoping that you can look into, let's say you have a patient who was a failed induction and you're like, okay, that patient, she's an NTSV cesarean delivery for a failed induction. Where did she fall out? What was the area that maybe she didn't meet the ACOG MSM criteria? We're creating dashboards where you can look at that, review that data and say, okay, where are we trending? How are we doing? Hey, are we in the upper, lower, middle, or the really low, depending on where you are in the thing of meeting this cesarean delivery rates or having the highest percentage of NTSBs, cesarean deliveries that don't meet criteria. We're going to have lots of different things. If you have any ideas of things you'd love to see displayed, please feel free to email Ellie at her email, which is ellie.suse@northwestern.edu. She'll enter it into the chat box for you. But if you're interested and you have some ideas, please share them with us. We are very responsive to you as our leads. Number 5 is creating clear action items for the next meeting. So you've had your meeting, you've attended your webinar, or you've attended the webinars, you're having your meeting, people have come prepared, the data is being reviewed, someone shared the insights from the ILPQC webinar, and you've talked through what are next steps. It's so important to capture those ideas and creating clear action items. And as the team lead, you are going to be one of the most primary and important people for creating that. I do always encourage someone to be a scriber or someone to be the one who takes notes. So maybe it's the physician champion and the nurse champion who partner together and saying, hey, which one of us can take notes this time? Why don't you take notes and send out the recap email, and I'll lead this meeting and the next one will swap. Whatever it is, it's really nice to have one person who is helping capture those key takeaways. Maybe it's someone else that you just invite to the meeting who's, on the QI team, or not, is on the QI team in a limited setting. And maybe it's a resident who's just there just to learn for this one session, and you switch off for different residents so that if you're a teaching affiliated hospital, you're able to engage them in that way. It's really important, again, to just capture those action items and then also cast out who is responsible for that action item. And then the last element that we really encourage and a strategy for being a successful team lead is clear and short communications with follow-up. So again, this might be a reminder email. Hey, everyone, here's the agenda for our upcoming meeting that's being held on Tuesday. I look forward to seeing you. Very short, very clear, agenda listed below. Wonderful. Maybe it's your recap email. Hey, everyone, here's our recap email from Tuesday's meeting. You'll notice the action items and their deadlines that we've established, or maybe it even might be the deadlines, and we'll meet next month to talk about them. The goal here is really to let everybody leave that meeting feeling, hey, I know what's going to come next. I know what my role is in the coming next, and I have some sort of accountability. If people leave and the team is not leaving in action with like items to move things forward, then one, it really wasn't a successful meeting. And what you'll notice is that each month, you're going to be discussing the same things over and over and over again and saying, hey, did we make any progress on that? Oh, yes, you said you were going to be able to do that. Okay, but you set up a meeting, like trying to make some progress on that. Ellie, any comments or questions? I saw the chat box light up a couple times. I just want to make sure that no one had anything.
Yes, we just had one comment from Debbie Shy about if any Wave 1 PVB teams have reports written for Epic that can be shared, since we have so many hospitals that use Epic, to help to obtain patients that fall into each of the buckets and do random sampling.
Lovely. Okay, Debbie, great question. What we can do is we can send an email out to our Wave 1 teams and seeing if anyone has any of those things developed. I know that our neonatal teams for basic, we did ask who was using Epic. I don't think we captured that information for PVB Wave 1, but we can definitely do that and hopefully offer some insights on our upcoming webinar. For PVB, our upcoming webinar is being held December 14th. And then our basic webinar, I believe, is December 21st. But Ellie, would you verify those two things? And then we'll add them to the chat box at the end of this presentation, just so everyone has it. But yeah, keep asking your questions in the chat box as they come up and they pop up. I'm happy to answer them as needed. So as I move on to the next thing, I just want to make sure I, recap this, is that these seem very elementary. They seem like, oh yeah, we all know this, but they are so important. And it really brings us back to the basics, back to the foundations of what we can do to be a successful team lead. Like I've said, after doing this for a certain period of time, often, in one of the things I've realized is that when teams fail, to make progress forward, or they're feeling stuck, or they're feeling frustrated, it's because there's usually been a breakdown in one of these key strategies. Maybe they're not holding those monthly team meetings. Maybe people are, great at coming to the table and having lots of ideas, but then they are failing in that next third ingredient of the execution, right? We talked about quality improvement is the will, the ideas, and the execution. So again, creating action items, short communications for follow-up are so important. All right, Ellie, I'm just going to take a quick pause here and take a sip of water, and then I'm just going to see if anyone has any questions before we move on about creating buy-in and engagement. Feel free to put them in the chat. Anything I can answer, Ellie?
Just some questions about dates for basic and the toolkit. So I'll put all the dates in at the end so that everyone has them.
Perfect, lovely. I love it. Thank you very much. All right, so moving on, creating buy-in and creating engagement with your hospital. Ooh, such an important topic. All right, so we know creating buy-in from nurses, providers, upper level administration is so important to the success of an initiative. Often, this is one of the biggest barriers that people share with us at ILPQC, whether that's through the annual conference surveys, through our quality improvement support or reach outs. People will definitely share with us and let us know, hey, I'm really having a hard time with buy-in. My hope for you today is to leave with some tangible tools and communication that you can utilize as you're getting ready to launch your initiative. So I'm going to ask the question, how do you lead people to enthusiastically get on board with a change? How do you get them to own the change in a short period of time? So you're like, okay, we've got this going. Oops, I'm so sorry. I must have clicked something. Let me go back. My apologies. Ellie, are you still seeing my screen?
Yeah.
Okay, let me circle back around where we all need to. Sorry, everyone. Here's our 3 ingredients, our systematic approach, the IHI model for improvement, 2 parts. Here we go. This is what a quality improvement's not. Keep going. PDSA is, yay, everyone. Successful ingredients, QI support, elements for you, creating buy-in. Here we go. Sorry about that, everyone. It sounds impossible, right? That like without the use of a special magic wand, and unless your hospital employees are these magical unicorns that just automatically, create change and make things happen. Well, honestly, the truth is creating buy-in and achieving this goal is really just around simply called clarity. You need to create clarity and provide clarity. So first you start with what we call a strong pitch. All right, a strong pitch as your communication can really make or break the reactions of your change initiative. I consider the support that you need to gain from all levels is really important because people rarely agree on how things stand. But despite the differences, you want to give them a way to generate agreement from the top down and to gain support on all levels. Your goal is really to help people arrive together on the current state and also agree on the need for change. If you skip this step of creating a strong pitch and generating support around your vision, it will definitely come back and it will bite you over and over again. I encourage everyone, the key elements also are to be transparent. It's so important. People are really drawn to authenticity. It's important to be clear on what you're working on and what is going well, but also pointing out what's not working and being honest about that. Even if it's true, as you implement the changes and perform your PDSA cycles and you're trying to say, okay, we tried this and it didn't work. It's okay. Creating authenticity is so important for creating buy-in. And the last thing you need to consider is ask yourself, if you seek feedback, right? Are you claiming to be open to it? Because often our actions show otherwise. This is an important step for creating real and lasting buy-in on a quote belief level, right? Where people understand and believe you. Providing a communication strategy is great, but you need to be open from hearing others around you as well, and then adding to that and editing as needed. People will do what they are comfortable with and will continue to do unless they feel conflicted otherwise. And so if you can help create buy-in, help people feel comfortable, be transparent, and ask for input, they'll feel comfortable. All right. So how do you convey a message on a belief level. I briefly mentioned that on the other side, but how can you be successful in conveying your message that's going to overcome challenges that are presented, whether or not that person is what we call an early adapter or a late adapter and change. And you'll remember from other probably presentations or things at ILPQC, there's a change adapters. And you have people who are early adopters and really excited and energized just really easily, or you have people who are what we call late adopters and they struggle and are like, hey, you know what, you just need to take a little bit of work to convince them. First, you want to, the first conversation you have with the individual is really important. So when you're trying to create buy-in, that first, hey, let me tell you, this elevator pitch is going to be extremely important in conveying short and concise messaging. Communicating what's happening and what's changing should happen early in your process. People should not be left in the dark and wondering what's going on. So this might be, hey, we just joined an ILPQC promoting vaginal birth initiative, everyone. We're really excited about it. We're going to be launching soon. We'll tell you more to come. Let me know if you have any questions or concerns. How you communicate that message can make or break your provider's reactions to your PVB or basic initiative. And again, you want this to be a really quick summary that defines the idea or the process, and it also provides a value proposition. Make sure that you have a persuasive pitch, and that includes a strong and compelling story. You want it to be memorable. So this pitch, this elevator pitch, is a quick, like what you want to do, say, in an elevator ride. It shortly summarizes what's going to be happening. It defines your ideas. So maybe this might be, hey, for PVB, we're working on reducing NTSV cesarean deliveries by implementing a checklist that meets ACOG MSFM criteria. Our hospital it should spark interest for them. And you can be like, oh, tell me more. What would that look like? Next slide. Let's see if it goes. Does it work now? Now do you see it? Perfect. All right. So you might be thinking, okay, Autumn, I get it. I know you just said I need to have some sort of pitch that I can quickly, authentically share what we're going to be doing and be very quick. I want to be able to share that with the nurses and the physicians that are on ground level, but also with administration. I know that, this seems so elementary, get it. But what I really want you to do is I want you to think about the fact that you are a conduit for information. As the team lead, your communication strategies and your expertise is a key ingredient. So what do you need to consider when you're creating your elevator's pitch? And I would actually encourage everyone after they get off this call as a team lead to really come up with their elevator pitch. So what do you want to communicate? Maybe this is that elevator pitch to energize and get people really excited about what's going to be happening for your initiative. Who are your stakeholders and what's your target audience? When you're talking to your staff nurses and when you're talking possibly to your administration, it's going to be a little bit different what you talk about, right? You might share some different type of excitement. For example, you may talk about cost benefit when you're talking about your basic and your antibiotic stewardship. Maybe you're talking to the patients or even maybe the nurses on a different level. But either way, you want it to be short and very informative. Again, one of the biggest things you can do is keep it positive and upbeat, be energized about it, and then also practice it. Get some feedback from your QI team. Maybe you host your first monthly meeting and you guys we're going to work on an elevator pitch. We know our communication is so important. We want to make sure that we get an early start to communication and obtaining buy-in. We want to make sure everyone is very clear and has concise, clear information on the launch of our initiatives and what that's going to look like. So let's meet together and let's practice it. How does this sound? What do we like? What don't we like? Now, again, don't overthink it, but keep it short and concise, and maybe even practice it out loud and have it. So the 4 key components, and you guys can take this slide, which will be available to you after the call. You can literally say, here's what we're working towards. This is important because, and again, we will know we're successful when. So how will they know? People always appreciate knowing what direction they're going to go in. They want to know, hey, like, are we working towards this? when will this end? Because it's like, oh my goodness, especially in the times of COVID, getting buy-in and getting people energized and excited is really important. And then also a really last but not least important concept is really making sure you share what you need from them. So maybe for your, administration, it's saying, hey, we just need you to be aware that these, conversations are being had, and we'll keep you informed as things move on. Because maybe they don't need to know a lot right now in this early elevator pitch and this initiative launch. Maybe they just need to know what's happening, and they can get excited about it. There's a lot of different things that they're thinking about. Maybe it's for your nurses, and you're thinking about, your nurses, and you're saying, hey, what I need from you is stay tuned, because we are going to have labor management support classes and strategies to help learn different positions that we can put patients in when there's a dystocia, or how to help with pushing when we have a prolonged second stage. Like, how exciting, right? You're getting them like, we need you to stay energized and get excited about this. This is coming your way for you. So again, that's creating that positive excitement that's there, and then also being very clear and authentic with people. I guarantee when you do this, IHI did a whole series about how to speak so leaders will listen. Everyone's really a leader, in their own way. So it doesn't have to always be from that top-up approach. It can also be as a grassroots with your, staff and employees that are at the hospital. All right. Questions or comments? I'll leave a minute here before we move on. All right, moving forward. So where to start? We do have useful QI tools that can help your team prioritize the multiple change ideas that you're considering. So both the PVB initiative and the basic initiative, when you attend their calls next month, you will notice that they have what we call key driver diagrams. Those key driver diagrams have what we call change ideas and what we call drivers for change. And there's primary drivers and secondary drivers, and then the change ideas for those drivers. Our change ideas might be a little different than your change ideas, or yours might be tweaked on some of those, simply because each hospital has their own clinical culture and their own way of doing things. And so a prioritization matrix is a useful tool to help you identify where to start and what comes next. So when we launch those QI key driver diagrams next month, and you're able to see them, and some of them are currently available online, like for PVB, you could check that one out. It's currently online. Ellie, you can put that in the chat box if you'd like. You can begin looking at some of those drivers and where do we want to start? And then this prioritization matrix, what you're doing is you're really scoring these different change ideas, positive and negatives, and determining like which one is a high priority. I can hold if someone's interested in this, I can hold an additional webinar if people are really interested, but for time purposes, we're not going to do an example of this today. I will also be very honest with you that ILPQC, having followed in the steps of other successful PQCs such as Florida and California, and learning from their small tests of change and creating our own change series and ideas, have learned a lot from them. And so they've really shared with us, hey, here's a really great place to start, and this is what I suggest. Anyone who has attended our ILPQC's annual conference probably remembers, like for Dr. Dimitri Duchovny and Dr. David LeGroux, that they really did share some of these lessons learned. So our hope, just so you know, is that our calls that we have set up for you starting January 2021 will really help prioritize what we believe are important change strategies. For example, you heard me mention at the top of this conversation, we know that EMR builds are going to take some time. And so starting that conversation early and elevating that would be important. But what we do have available for you right now are what we call our 10 steps to getting started. Each initiative, basic and PVB, have these 10 steps. You'll see they are slightly similar. There is some nuances and differences, but this is really a great ingredient for the launch of your initiative. It walks you through what are some things that you can start thinking about, what are the things that you need to start doing to move things forward, what are some of the key QI strategies. And so you'll see them listed under number 5 in PVB, and you'll see them listed under number 6 in the basic one. And those are some key QI strategies that actually connect to our drivers. I don't know if the basic one is on the website just yet. I think it was released at annual conference. So I don't have a link for that one, but we can probably put a link to the 10 steps to getting started in the chat box. But I think that one was, actually, I think that one's set up yet, right? We launched it at annual conference. So those will come. We'll send again, when we send this recording out, we will send the links to those as well. So I would just encourage you to make sure you go ahead and take a quick look at those 10 steps before and even during maybe together your first QI meeting before the launch calls and the kickoff calls that happen next month for both basic and PVB. Well, that was great. I have 9 minutes to spare, which is I was hoping for 5 minutes for a short Q&A session to see if anyone had any questions that we can answer about any of the upcoming initiatives or in regards to presentation, or hey, I want to make sure I have a good understanding and a clarity of what my role is as a QI team leader in an ILPQC initiative. So you can either enter something into the chat box or you can feel free to go ahead and come off mute if that works for you. Other than that, I think if you would like, everyone, you can go ahead and begin to jump off unless you have some questions. I'm going to say thank you so much, everyone, for joining us. We're going to stay on the line and just answer questions and go back and forth. And Ellie, just let me know if anything comes through. Oh, thank you, Emmett. Thanks, Joe. And again, if you didn't get a chance to put your name into the chat box, you can go ahead and put your name in the chat box and what hospital you're from just for attendance. Crystal, we will send these slides out in the recording as well. I did see a question from Pat Baker. What months are baseline data collection for PVB? So great question, Pat. For our baseline data collection, we are doing Q4 of 2019, which is the months October, November, and December of 2019. For the basic data call, you do not need to attend both calls. So we do hold what we call ILPQC data calls. This is where we give a little bit of a REDCap overview. Hey, what is the REDCap data system? How do I enter? How do I log in? What does the data system look like? How do I enter my user ID? We kind of just give a really basic one, basic for basic and PVB. We hold them twice a month. They're kind of sprinkled in so that we can accommodate various people's schedules, and it's really just digging a little bit deeper into the data form for you. It also has a Q&A section. Ellie has, we can share the dates with those. I know one is November 30th, and I think the next one is next week, Wednesday for the basic. And then I believe next week, Thursday is our last one for the PVB team.
Yes, basic is 11-18, 11 to 12, and PVB is 11-19, 1 to 2.
Lovely. Perfect. Thanks everyone for continually putting your names in the chat box. I really appreciate it. We've had a lot of people jump off. I'm just kind of scrolling through the chat box myself to see if there's any, questions. And Ellie, if you see something that maybe I'm missing, you can let me know. Thanks, Catherine Robbins. Always appreciate the nice excitement from everyone. Elizabeth, I'm glad you enjoyed the call. All right. Oh, Heather Brown asked, what can we repeat the months we need to pull the data for baseline? So this is specific for PVB. For PVB, which is our OB initiative that's launching in January of 2021, but we have our kickoff webinar, which is on December 14th. Baseline data collection for PVB, promoting vaginal birth, will be Q4 of 2019, which is the months October, November, and December. Thanks, Erica. Good to see you. Hello, my friend Gail Goldberg. Thanks for putting your name in. All right, I think we're all good. People just are kind of putting in, I think, their names in the chat box. We'll let them keep doing that. Oh, Erin said that Q4 for them, UIC is through September to December of 2019 for PVB. So Erin, again, if you want to, for us at ILPQC Q4 is kind of what we call October, November, December. They're in 3 months increments. If you want to put in September, I will have to double check with Dan about that because I don't think we'll have a month available. So for the baseline data collection, but go ahead and actually just email, give an email over to Ellie at ellie.suse, S-U-S-E, at northwestern.edu, and we can make sure we follow up on that answer. All right, I'm glad you got it, Erin. Okay, well, I'm going to officially sign off. It looks like all of our main questions came in. Everyone, thank you so much. Happy Friday. Please stay safe and strong and healthy, and enjoy the sunshine we have today while we have it. We know when winter comes, sometimes the snow is not so sunny. So enjoy the sunshine. Have a wonderful weekend, everyone. We look forward to seeing you either on our data calls next week, which is Wednesday for basic, Thursday for PVB, and then, of course, in December, we have our launch calls. December 14th for PVB, and December 21st for basic. All right, everyone, have a wonderful, wonderful weekend, and we will see you all later.